Finally, we come to hormonal therapy. You need to understand that there is a difference between premenopausal and postmenopausal hormonal status. Both of them, estrogen plays a role, but where is the maximum production is what matters. In premenopausal, maximum is from the ovary. In postmenopausal, maximum is from fat conversion or the peripheral conversion in other terms. Peripheral conversion. Okay, so this is the concept that you need to understand. Now, let us look at each of these. What do you mean by SERM? SERM are basically, the full form is selective estrogen receptor modulators. So what this actually means is, these drugs, there are two different cells, okay, and both of them have the estrogen receptors. In one area they can stimulate the cell, whereas in the other cell they might inhibit the cell. Okay, so it depends on the site where the receptor is. So it is selective, as in certain areas it is a estrogen receptor modulator. So it is neither a inhibitor nor is it a stimulator. It can act as both depending on the site. So it is very selective as to where it acts as an inhibitor, where it acts as a synthesizer, or where it can act as a stimulator. So two areas that you need to remember, one is the breast, one is the endometrium. So these SERMs in the breast, they act as inhibitors. Okay, so they prevent growth, whereas in endometrium they proliferate growth. Okay, now why is this important? You will think that you are giving SERM in order to treat breast cancer, but at the same time you are exposing them to endometrial carcinoma because you are proliferating the endometrium there. Okay, so that is why this is very important. Now let us see how we are going to manage premenopausal and postmenopausal. So in premenopausal we have said that maximum is from the ovary, and postmenopausal it is from fat or the peripheral conversion. So these SERMs will have a role in premenopausal. Okay, because there is a lot of ovary which is being secreted that acts on the breast. So you need to give this. So at the advantage of preventing breast cancer, there is a risk of endometrial cancer. Whereas in postmenopausal, we know that it is only fat conversion. There is nothing coming from the ovary. Alright. So there is one specific class of drugs called as the aromatase inhibitors. Okay. So these aromatase inhibitors only prevent conversion of fat to estrogen. So they only prevent this, they don't do anything, they don't act like these SERMs where they stimulate in one place and they inhibit in the other place. Now, is there any role for aromatase inhibitors in premenopausal? No, because majority is from the ovary. Okay, from fat is probably only 5%. So if you give aromatase inhibitors here, you are inhibiting only 5% of the estrogen. What about the rest 95%? You are not inhibiting it. Whereas in postmenopausal, almost 100% is from here. So you just give aromatase inhibitor, that's enough. So why not SERM here? Why do you want to take the risk of endometrial carcinoma? So with aromatase inhibitors, there is no risk of endometrial CA. That is why postmenopausal you are going to give aromatase inhibitors, and premenopausal you are going to give selective estrogen receptor modulators. So if you have understood this concept, you will understand how we manage the hormonal therapy.